It's actually a blue state. I'm not sure why it was red on this map, but it is in the United States. It's not in Mexico itself. And here is a detail of the state, and the little sun is where Laguna Pueblo is. You can see that it is west of Albuquerque. We actually have a very small, anybody from Mexico in the room? Or Texas? No? Okay, pretty safe. So I'm sure you've heard about our wall that the U.S. is planning to build. Actually, New Mexico, we're lobbying for it to be built around Texas instead. It's a little bit longer, but that's what we're trying to do. So, what is Laguna? Laguna Pueblo is a reservation, one of the 23 reservations in the state of New Mexico. The term Pueblo is obviously a Spanish word, and it refers to both the people and the reservation itself. When the Spanish came through in the 1500s, they saw natives living in towns, and so they called them pueblos, and that has stuck. It's interesting coming here to England. I grew up in Virginia, which is a British colony back in the day. This looks much more similar to where I grew up than New Mexico does because of the British versus Spanish influence. It's very, very interesting. There's still very much a old Spanish colony in New Mexico. Anyway, the Pueblo of Laguna has a population of about 3,800 people and a density of 4.9 people per square mile. I'm not sure what that is per square kilometer. I didn't do the math, but it's pretty sparsely populated. So it fits the U.S. federal definition of frontier. And though there is a major highway, Interstate 40 runs right through the middle of it, the Laguna Reservation, like many American Indian reservations, remains geographically and culturally isolated from the rest of New Mexico. And such isolation is much more dramatic amongst the medically fragile elders of the tribe. Now, the Pueblo of Laguna Fire Rescue actually is a very well-funded and organized fire and rescue department, unlike most of the departments in rural New Mexico. There are 3 stations that are staffed 24/7. There's a total of 8 to 9 firefighter paramedics on each shift. And usually at least one and more likely 2 of them are advanced care paramedics. So again, an unusually high level of EMS care, of paramedic service care available in the community. Last year they had approximately 1,600 calls for service. So that's emergency and also some non-emergency transports. They primarily transport patients to Albuquerque, which is about 70 some kilometers to the east, although there is an Indian Health Service hospital that has 25 beds, and no CT scanner, a very limited capability that's 24 kilometers to the west. So this group knows very well what most community paramedic mobile integrated healthcare programs are like. Some of them, of those types of programs, focus on reducing hospital readmission. I mean, we heard some of that yesterday, some very interesting stuff. And others focus on navigating folks away from the 911 system, particularly the non-urgent stuff. But most of that involves significant education above what typical paramedic training involves, and mainly to create what I like to call as semi-independent practitioners who can go out and do things without contacting physicians or the like. The state scope of practice for New Mexico, in the United States, EMS is very much state regulated, and each state sets their own scope of practice. And the state scope of practice in New Mexico is actually rather forward-thinking and specifically allows for community EMS, community paramedicine in the state scope. And you don't have to read the small type, and I left off a whole lot more small type. But basically, it says if a community paramedic takes a EMS Bureau approved community paramedic course, then they can begin to be part of a community paramedic program in the state of New Mexico. But again, this is aimed at developing and supporting the semi-independent practitioners. And as we have talked about in this forum yesterday and over the past few years, etc., that kind of training is very extensive, as it should be. But that really puts it out of reach of many small rural U.S. agencies just because of time and expense. So Emily touched on the Indian Health Service a little bit yesterday and gave you an introduction to that. But to really understand why tribal agencies are so well positioned to start successful rural EMS community paramedic programs, you have to understand a little bit about some of the other aspects that IHS provides. And the real big one that helps us a lot, besides the funding, is the Community Health Representative Program. Now, I believe that this was mentioned, a community health worker was brought up yesterday in one of the presentations, and that program is very similar to the Community Health Representative Program. The CHR program was formed in the IHS in 1968, and since then, CHRs have operated on American Indian reservations as kind of as paraprofessionals that attend to the general health of tribal members. CHRs visit patients in their homes, help with general health maintenance, they talk about health promotion, health advocacy, and they often help with health-related transportation, taking them into town for appointments and stuff like that. Patients are referred into the CHR program by local hospital, by patient physicians, and really most often by word of mouth. I mean, this is a very small, tight-knit community. Everybody is related to everybody in some way or another. So you really hear about that word of mouth fairly quickly. So it was from this infrastructure, the CHR infrastructure, that the Laguna Community Paramedicine Program arose. The CHRs are in the communities every day, and they already have an informal needs assessment. I mean, they know what patients need in the community because they've been doing this for years and years. And they were also aware of the medical needs that were outside of their scope of practice. CHRs don't have much of a medical scope of practice at all, so they don't have the ability to take care of a lot of medical problems in situ. They have to take them to the physician's office or take them into specialty care, etc. And more importantly, they're aware of needs that weren't being met, and in particular due to geographic isolation and lack of transportation, etc. So it was this kind of informal needs assessment that led them, the CHR department, to approach Laguna Fire Rescue about developing a community paramedicine program. So we met with the CHRs, the fire chief, and the medical director, that's me, and we determined that from this list of unmet needs, we could train some of our guys to go out and do some community paramedic tasks. We picked two of our paramedics, two of our advanced care paramedics that actually had a lot of experience to be the first community paramedics. And based on the needs assessment that had been informally performed by the CHRs, we picked wound care and medication management as really the first two major areas of attack for our program. The wound care in particular was very important for the CHRs because many of those patients needed a specialty wound care in Albuquerque, and a single visit just for a dressing change could take 3-4 hours of a patient's time and a CHR's time several times a week. And because of this, patients were missing appointments and were quite literally rotting away in their own homes. So that this was something that was a very, very dramatic example for the CHRs. So we had 2 guys, and if you remember, we've got 8 to 9 on a shift at a time. The average turnaround time for a regular EMS call there is 3 to 4 hours due to response time, travel time to the hospital, travel time back. We couldn't spare 2 of our advanced care paramedics for a extensive community paramedic training in Albuquerque. Is the only place to get it in New Mexico for a year or longer. So we decided to build the program in the opposite direction. So instead of providing general community paramedic training and then looking for patients to fit the skill set, we came from the other way. We knew that we needed wound care assistance, and we knew that we needed some medication management. So that's where we started. So we first sent the guys out with the CHRs, just doing ride-alongs, primarily to learn their workflow, learn what they did, learn how to approach patients in that different kind of a setting. Still a house that paramedics are used to going into all the time, but it's a much different flavor, as you know, coming in a non-urgent fashion and dealing with different complaints. So the visits that they went to were primarily, they were preferentially sent out to visit the patients that needed the complex wound care that the CHRs couldn't take care of. And because of that, they often got to go into Albuquerque to these specialty care wound care appointments, so they were able to start getting the training that the specialty clinics would be normally giving to family members, et cetera. So they were already getting some basic wound care management directly from the specialists. So, of course, that's not what the patients needed. They needed much more advanced wound care. So in December of 2015, both of the community paramedics went to, it was actually Oklahoma City. I was corrected last night via text. Oklahoma City to complete wound care training. And this greatly expanded their skills and experience with complex wounds. And I meant to write down the actual certification that they got. I thought I did. Maybe I forgot last night after the Best of Britain evening, or perhaps it was the open bar. But they do have a wound care certification that is recognized throughout the United States by wound care professionals. So they now have training that is far in advance of certainly anything I know about wounds. I mean, put a bandage on it or something. But they have some very advanced wound care training, and so this has really expanded their skills and experience with complex wounds. Now, medication management was also identified as an important topic for our community paramedics. And what we found out with this is that most of the medications of interest were already in the advanced care paramedic scope and knowledge bank. So these are medications that they don't necessarily give on a regular basis, but they deal with or deal with the effects of. And so they already knew a lot of the indications, side effects, dosages, et cetera, for these medications. And so this made this getting this portion of the program off to an easy start. And quite frankly, whenever they have encountered some medications that are different, because occasionally we'll have patients on some really weird stuff, they'll just give me a call and then I'll look it up. But that has worked out very well. Most of the medication issues have actually been with family members afraid to give pain medication to their terminally ill grandparents for fear of constipation, which actually is a big deal, of course, and it's a real big deal for elderly patients. But I've actually been on several house visits with the community paramedics and seen, the grandpa in bed in pain from the chronic illness and not being treated, and just being able to watch the community paramedics discuss, how to titrate pain medication with titrating a bowel regimen. It sounds simple, but it's a real impact on the quality of life of a lot of these folks. So here are the two community paramedics on the left side, Fernando and Tony. Fernando is Native American, but of a different tribe. Tony is whiter than I am, which is it is a big deal especially going into some of these very isolated homes, not being from the community, and that's why it was so helpful to have them riding along with CHRs to start with. And then, of course, that's me. We were presenting a poster on the project back in October at a underserved care conference at UNM. Now, it's not by accident that I showed that picture, and that picture included me, because as we've discussed before, there's a big difference between the semi-independent community paramedic and what we're doing out here in Laguna. This is something that definitely involves the medical director as a partner for the community paramedics a lot more than some of the other programs that I'm hearing about. These guys have not gone through a college level, degree level course for community paramedicine, and so since they're starting from one piece at a time, it does require a lot of involvement from me and the rest of the physicians in our group, and this also requires a lot of frequent quality assurance, both indirect, talking about it afterwards, and just going out with them and interacting with them and watching them in the field with the patients. And what this also means is being available for phone consultation in real time. Hopefully, in the near future, we'll be able to add video as well. And this is one of our vehicles. You can see there's a whole bunch of antennas on top, and there's room for more. So we can definitely put something in there for some televideo conferencing. So, what about numbers? One of the things that I heard a lot yesterday was we're so excited that community paramedicine is no longer a pilot. It's actually, in many places, it's an established program. Well, we're kind of in the spot where this is a pilot. It's the whole program. The plane's not going to get any bigger, so it's just the pilot and the co-pilot. However you want to look at it, it's a small program. It's a small inn. But this is what we do now, and we're continuing to make it better. So the first patient was seen on the 10th of September in 2015. She is now 90 years old. She's still a patient in the program. But her mother lived to be 108, so we got a while with her. The community paramedics have now made 221 visits to 11 unique patients over this year and roughly a half. For comparison, the CHRs themselves followed 131 unique patients in Laguna in 2016, and there are four CHRs that covered that. I didn't have the exact number of visits that they had, but they had quite a few. So you can see that the number of specialty visits that require the community paramedic is a small subset of what the CHR program is doing. So those are the numbers. And then results. Well, there is, it's really difficult to quantify the results of community paramedic programs in general, and we hear about that over and over. We're trying to figure out how much money we save, all this. It's difficult to quantify, and there's no question that the vast majority of reservations in general are underserved. And though we have discovered, we've discovered specific examples of patients missing appointments that are far off the reservation, that patients that have been slipping through the cracks. We really have no good way to quantify what degree of medical need is being unmet. So it's really hard to show the positive effects of this CHR community paramedicine partnership because we feel that so many of the things that the guys are taking care of right now were just not being taken care of before. So not only is it hard to figure out how much money we're saving, we might actually be costing more money because we're getting patients into to medical care more. It's really hard to calculate quality of life years added because that's what we think is going on. We're trying to estimate the costs of specialist care on and off the reservation, out of the IHS network, that these patients should have been receiving, but in many cases were not, and then comparing them to the costs under the model. But we don't have a good handle on that yet, and I'm not sure that we ever will. But the anecdotal results are especially promising among the wound care patients. And the patient and family testimonials have been very positive. This is something that I hope other programs in the audience and elsewhere are using, but you cannot underestimate the impact of a family testimonial at a tribal council meeting, for instance. All it took was the first patient's 70-year-old son to get up in front of tribal council and tearfully explain what we had been doing to basically give us a blank check to continue and expand the program. So don't overlook the power of advocacy from your own patient base. Here's some early morning pictures here. Since we don't have actual results, we'll go ahead and show you some details. This is patient number 1. She was 89 at this point, and that is her left ankle. That is very literally rotting off of her at that point. And this was the first visit that they went to take care of her. And you can see through the progression. This was in December of 2015. You can already see that we're starting to get some nice granulation tissue there. The borders are pinking up. It's starting to look better. And then by August of 2016, it's looking a whole lot better. But this, I mean, you just see this was a span of 1 year right there, and that wound is still there. So this is not, I mean, we all know this. This is not a, one call and you're done type of thing. This is an over and over and over visit to this lady and other patients like that. And this is, here she is showing off a freshly bandaged wound the other day. Obviously you can't see what's underneath, but you can see that she is very proud of it. She's pulling back her pants there, and it's probably Fernando holding it up. What are the thoughts for other areas? This is very specific to Laguna Pueblo for sure, but everything that we should be doing in Laguna, everything that you guys should be doing needs to involve reproducibility. We've got to be able to do what we're doing here elsewhere. It may be a little bit different, but we've got to be able to give back to the field of paramedicine, to community paramedicine. So thoughts for other rural areas. The focus of our program in Laguna is on discovering and addressing unmet and underserved medical needs that are amenable to home-based treatment by EMS providers. And this has really allowed us to build this program one need at a time around specific community needs, and not according to specific community paramedic curricula. We've really benefited from the infrastructure and IHS funding that for home health care that is not available in non-tribal areas. And this is something that we really want to take to other tribal EMS agencies as an example, and we already are, that maybe you'll hear about at the next IRCP. But what we've really realized is that the community paramedics in our situation are as much CHR extenders as they are physician extenders. So they're really expanding on what was already there instead of expanding on what physicians do. Now, full spectrum community paramedic programs, at least in the U.S. For right now, may be out of reach for rural areas. I mean, the stuff that we heard about yesterday in Minnesota, yes, Minnesota or Wisconsin? Wisconsin. I always mix those two up. I apologize. The full, it's really impressive to hear about the broader spectrum programs there. But for a lot of the rural U.S., I mean, that is just really out of reach. I mean, we struggle to get people to first responder courses or primary care paramedic courses. But this shows that until we get to the point in the United States where we can fund this and we can pay people to come back and do this kind of work at a reasonable wage in rural areas, that it's possible to build a special skill set, one skill at a time based on community needs. Now, it's a whole lot easier to start that as an extension of a CHR program or a community health worker program. There are some non-reservation community health worker programs in the United States. There aren't that many. It's a lot easier to build it from such a program. But without that kind of a program, the community paramedic program really needs to go out and do its own needs assessment, which I think was well described in some of the presentations yesterday. So we've been very lucky that we didn't have to start there. Funding concerns. Emily also mentioned a little bit of the somewhat magical funding that we have in the Indian Health Service that others don't have. It is much easier for U.S. tribal paramedic agencies to do community paramedicine because of tribal control, direct control over IHS health funds. We have direct access to the decision makers, and it's very easy to convince them to pay for these programs. But the U.S. insurance companies are becoming more aware of the community paramedicine concept and are more willing to explore such options, or at least they were. Who knows what's going to happen in the next few months. So what's next in Laguna? We are really looking to build the program. We want to add a couple more community paramedics. We want to get daily coverage, because right now the two guys are going primarily on their regular duty shift, which is the 48 on, 96 off. They do come out to visit patients on their days off, but it'd be really nice to get a little bit more coverage during the regular duty shifts, or to get protected time for them. We need to keep watching to see what the next need is. So we've made a dent in the wound care. We're doing well with the medication management. What's next? So we're going to continue to meet with the whole team, the huddle. Somebody mentioned the huddle concept yesterday. We'll continue doing that. And we'll consider other things like point-of-care testing, maybe some simple antibiotics, pediatric asthma action plan. That is one that has been done in some other U.S. areas that I think would be a very good one to investigate. So we're definitely looking forward to the future. Happy to take a question or two. This is me and my daughter right after. Anybody read Gems here? Gems magazine? I'm sure somebody does. This is right after we took some pictures for an upcoming article. So when you see that article, you'll know that she was actually really okay. But she really handed up for that article. So, or maybe we just upset her and she cried. But all right. Well, thank you very much. I really appreciate the opportunity to present here.